Hello, everyone, and welcome to the third season of McGill Cares webcast series supporting family and informal caregivers. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret from the Division of Geriatric Medicine, and my guest today, Dr. Serge Gauthier, Professor Emeritus, formerly of the McGill University Research Centre for Studies in Aging. McGill Cares is supported by the Amelia Saputo Community Outreach for Dementia Care. So to kick off the third season of McGill Cares, the topic that we will be discussing today is staging in dementia and Alzheimer's disease. Dr. Gauthier, who is my guest today, is a clinical neurologist specializing in the development of new tools for diagnosis and treatments for people living with Alzheimer's disease. He was the director of the McGill University Research Centre for Studies in Aging from 1986 to 1997. Dr. Gauthier is the academic co-lead for the Dementia Education Program and Professor Emeritus, Neurology and Psychiatry at McGill University. His accomplishments led him to being appointed to the Order of Canada in 2014 and the National Order of Québec in 2017. So after a diagnosis of dementia, the next question that often comes up for caregivers as well as the person who's being diagnosed is, at what stage of their dementia journey is the person I am caring for in? So Dr. Gauthier is with me today to explain staging in dementia and why it is so important. Welcome, Dr. Gauthier.
Merci, Claire. Good to see you again. So hello, everyone. Thank you for the opportunity to talk about staging of dementia, that is in people who already have symptoms. But it's an opportunity to explain a new proposed classification of Alzheimer's disease that would start before you have symptoms. And it's important because it would bring this Alzheimer's disease to the same field as diabetes, where diagnosis can be done long time before you have complications, and to some degree cancer. So I will use some slides to explain this, and maybe Claire and we can have some interaction at the end if you have questions. So the content overview is why staging of medical conditions in general is important. I'll give you some examples like diabetes and cancer. The classic staging of dementia is based on symptoms since the past century. There's new evidence and information that is available that even in the living person, we can see the brain pathology as it builds up in the course of Alzheimer's disease. Also, there are new blood biomarkers that can add to the imaging that's possible of the brain. And I will have conclusions at the end why this is important and what needs to be done in the near future. So disease staging in general is important, whether you have cancer or diabetes, again, classic examples, but any condition. I think the next thing people ask after diagnosis, okay, where am I in the course of the disease, and what should I expect next so I can plan ahead? So as is stated here, nearly all conditions have a framework for ranking progression. And there's more history, perhaps in the field of cancer than there is in the field of neurology. Parkinson may be an exception. There's a staging of 1 to 5 that hasn't worked very well for Parkinson for the past 40 years. Now, staging can be based, again, in general, in medicine, on clinical history alone, where the symptoms are at, on physical examination, that's particularly true for Parkinson, anatomical distribution of pathology, that would be the case for cancer, for instance, or biological testing, as it is for diabetes. There is a classification for cancer that is now used worldwide, the tumor node metastasis, TNM. And this is based on biopsies or surgery where the cancer cells are located and do they spread. So that's an example of staging based on a number of factors. And again, diabetes may be a useful example because there is a silent phase where your blood sugar may not be going back to normal after a big meal. And there are other changes in the blood chemistry long before you have the need to go to the bathroom more often, or you get thirsty, and eventually much later you have trouble with your vision and your kidneys, and you have numb feet. So you see now there are examples in the field of medical disorders where there are silent phases, mild symptomatic phases, and sort of late stages. So why is it important? It's because there are, in many conditions, specific milestones. So if you reach a certain stage, this will change the management. This may be true, for instance, for Parkinson. You would use levodopa or other drugs if you have a minimum of symptoms that interfere with daily life. Surgery also is a classic example. So if you have a certain stage of cancer spread, you may go straight for chemotherapy rather than surgery, and so on. And more practically for dementia, the stage you're at will determine to some degree the care that you need, but it's important to know what's next so you can plan ahead. So staging of dementia is based on symptoms, the classic approach for the past century. What are the symptoms? So they can be quite varied. Decline in more than one cognitive domain, such as recent memory, is the classic presentation, especially over age 70. But some people start with looking for words or directions or have trouble identifying faces. So there may be different symptoms at the start. Then these cognitive changes interfere with your daily life, such as driving your car, finding your way around. More commonly, it's handling bills, taking your pills on time, and eventually wearing appropriate clothes for the weather and walking safely. So there's a variety of impact on daily life as the disease progresses. There may be mood changes, perhaps aggressivity. If you know what's happening, the changes are happening in your life. So at different time in the course of dementia, there may be mood and behavior changes. They may fluctuate, they may disappear and come back. So the classic stages of dementia are mild, moderate, severe. And in the World Alzheimer report that Claire and I, with Dr. José Moret and Dr. Rosa Neto and colleagues are putting together from September 21st, we are using a more friendly term, early, middle, late. So if you read the World Alzheimer report, you will see those terms used for staging of dementia, early, middle, late, but they correspond to what we say in clinical practice, mild, moderate, severe. Here are some examples. These are beautiful drawings made by an artist that works with us at the Division of Geriatrics and Department of Education on dementia to illustrate some of the functional impact of mild, moderate, severe stages of dementia. So this is an illustration in mild stage. The elderly lady is having trouble paying her bills online, and her daughter or younger sister or friend, neighbor is having to help her. She can still live alone, but she needs assistance for what you call instrumental activities of daily living. So that's mild dementia. Moderate dementia, you need assistance to select your clothes, sometimes to put them on. You could live alone, but you better have a friendly neighbor or children nearby. You need definitively assistance for more complex tasks. That's moderate stage. And more advanced or severe stage, you have changes in the way you walk. You're more at risk of falls, so you're not living alone anymore. You may live at home with someone living with you part-time, full-time, or you may move to a residence with assistance around the clock. Another way to look at stages in Alzheimer's disease more specifically, but to some degree it's similar for dementia at large, is, as you see on the left, mood changes. There may be subtle changes in your interaction with your family, your colleagues at work. You have a bit of a social withdrawal, or you may be anxious because you're not performing as well as you used to. So there may be this what we call minimal behavioral impairment stage. Then you have cognitive decline, which is usually memory. It's subtle. You may compensate for it. It's not yet dementia. And then when you cross a certain line, functional autonomy, you need help to pay your bills, as we illustrated, or you need someone to make sure you take your pills on time. Then you cross the line into mild dementia. And then you have another period of behavioral changes that classically for Alzheimer is moderate to severe stage, where you have sometimes being up at night because you don't recognize your house or your spouse. And these improve with time, as you see here illustrated. And then motricity means this difficulty walking that was illustrated with the third set of pictures, where you have difficulty walking and you can fall. And this is usually accompanied by muscle rigidity. You may have trouble swallowing, and you may have a pneumonia from swallowing fluids into your lungs. So that's a good example of staging based on symptoms. Now, can we do better than that? Well, there's the pathology. So all the way back a century ago, in a way, we were fortunate that Dr. Alzheimer and other pathologists and psychiatrists in Germany studied the brain of a young lady in her 50s with Alzheimer's disease. And they saw with the optic microscope some changes that are still to this day the classic findings: plaques and tangles. I will show an illustration of what they look like. So this is post-mortem, but it could have been from a biopsy taken from someone earlier in the disease. The plaques are clusters of cell debris, and they contain certain proteins, which I will talk about in a second. And tangles are within the nerve cells. Here they're black because they're colored with a stain that is like silver. They're not black really in real life. They are changes within the nerve cells, and they're due to another change of another protein. And that took another 50 years to find out what these proteins are. So that's the next step. Brain pathology of Alzheimer's disease. We knew what it looks like with the optic microscope. And then there was the finding in the 60s and 70s. What are these protein changes? So beta amyloid is actually the key finding in the plaque. This is a fragment of a large protein, APP, beta 42. It's 42 amino acids, and it's sort of clumped into these plaques that you can see with the microscope. And now that we can see with PET scans, as I will illustrate in a minute. And then the tangles are made of tau fibrils. So tau is a protein that is essential for the good health of the nerve cell. It's excessively phosphorylated with age. And in Alzheimer's disease, it clumps, as you can see here, into tangles that interfere with the natural flow of material across the nerve cell into its terminals. Another step. Pathologists, older ones, younger ones, they saw that there are different stages over time. The spread of these changes, the plaques and tangles, it evolves over time. And one staging system from Dr. Tal is 5 stages for the spread of amyloid pathology in the brain. And for Tal, Dr. Bach and his wife, Madame Bach, found 6 stages. And why is that important? It's because we can see those stages now in the living person with PET imaging, as I will illustrate now. So this is taken from work done at the McGill Center for Studies in Aging. These are PET scans of various people to illustrate what the brain looks like when you give an injection in a vein of a ligand, a substance that tags into the brain onto the tau fibrils. You glow in the dark for half an hour, so to speak. And what you see at the extreme right is a lot of yellow and white. That means a lot of radiation for a few minutes in the brain of that person, in areas of the brain that correlate what you would see if it was an autopsy. So it's like a living autopsy, so to speak. You see in the living person the spread of the tau protein. Now, as you see on the right, 0 means stage 0, no neurofibrillary tangles in that person. And then 1 and 2 and 3. 3, you see a start of a bit of red in certain regions. That coincides for most of us into, what was your name again? So very mild symptoms that may or may not progress to stage 4, 5, or 6. Once you cross into stage 4, there's more symptoms, and we can usually have symptoms compatible with mild dementia. And then 5 is moderate, 6 is more severe. Why is that important? It's because we could scan your brain if you have minimal symptoms or mild dementia and say your stage for the tau pathology is 4. You should have this kind of treatment. Or you're already at stage 5, we should use another treatment. So that's the thinking. It's a bit like for cancer. Depending on the stage, you get the right drug for the right patient at the right stage. So what more can we do? Biomarkers. So now we're going to talk about spinal fluid and blood as a complement to what you just saw in the brain with the PET scan. So a definition of biomarker in general, it's an objective measure, something with a number. That may be an indication of normal biology, such as your sugar goes up after you have a meal, or a pathologic process, such as sugar in the urine after you have a meal that's not normal. In the context of dementia, it can be a measure taken from spinal fluid from after a lumbar puncture, or blood, or a scan, as we just illustrated. Because it is so spectacular, I'm going to show you now biomarkers that are from PET scans, but just be aware that very soon, within 2-3 years, we'll have validation of the equivalent of those PET scans from blood tests. And this is another contribution of the Montreal community. We have volunteers, participants in a cohort study called Triad, and blood from these volunteers has been sent to Sweden, and we were able to find things that are incredible, that some fragment of proteins called p-tau, phosphotau, with a number 181, 217, etc. They come from the brain and they leak into the blood, and they may be useful markers for the stage of disease you're at. So back to the modern concept of Alzheimer's disease, not dementia now, Alzheimer's disease, it's ATN. So to say someone has Alzheimer's disease, whatever symptoms he has, you need A for amyloid, T for tau, as we just illustrated, and N for neurodegeneration. So that means the protein buildup has led to shrinking of the brain or loss of nerve cells. Something else has happened to the brain. If you have all three, from a research perspective, you have Alzheimer's disease, whether you have symptoms or not. So just illustrations here, what we would see in the volunteers that come to the McGill Center for Studies in Aging cohort study, Triad. You have top left, the plaque that we just saw illustrated a few minutes ago. In the middle, you have an illustration of a tangle. And then the bottom, you have an illustration of changes in nerve cells. What's more important is all these types of scans. The top one is amyloid, the middle one is tau, the lower one is glucose. They're all available here in Montreal, currently for research. But eventually, if we find specific drug that work for specific stage and pattern of disease, we will have this available. So again, thank you for the volunteers who've had these 3 scans and a lumbar puncture and blood test every year for 5 years. Thank you. So now we're talking about a shift in thinking. Before dementia, you see changes in the brain with scans, and it's reflected to some degree by spinal fluid and blood biomarkers. And what's been proposed recently, 3-4 years ago, is that we add stages to Alzheimer's disease before dementia. We had a stage 1, no symptom, but you may have some plaques and tangles, silent. Stage 2, you complain at times on a Friday, oh, what was I supposed to do today? So minimal complaints, everybody has them. Nobody else worries about it, but it may be associated with plaques and tangles. And stage 3, you complain and you need to have Post-its to remember to pay your bills, but you still pay your bills on time. So it's not dementia. So what I'm trying to say is that there may be a 10 to 20 year phase of Alzheimer's disease before dementia, and we may be able to detect it. These are illustrations, what they would look like. Stage 0, you have no complaints, you function, you you're a volunteer or you work full time, no, zero complaints, zero problems. Stage where you have just a hesitation. What wasn't my password again? So if you're like me, you have a whole page of passwords. We forget. In stage 3, in the pre-dementia classification, it's what was I supposed to do today? And you have to look up your agenda more often, and maybe your daughter is picking it up. Well, Mom, you should know. But Mom can still live alone. She pays her bills. She takes her pills. No dementia. So this is the new thing. For Alzheimer's disease only, 3-stage before dementia, 3-stage after dementia. And this is making us closer to conditions such as diabetes and cancer, where we could intervene before symptoms are severe, moderate, or even mild. So the advantages is acceleration of research in the pre-dementia, stage 1 to 3. In the US, there are massive studies, like hundreds of volunteers getting injections of monoclonal antibodies to take away the amyloid in their brain, to delay appearance of symptoms or delay progression from mild cognitive impairment to mild dementia. And if you have mild dementia and you get this kind of biologic staging, you could get the new drugs if they're available and safe, or you can simply plan better what to do for the near or long future. So conclusion, staging of dementia into mild, moderate, and severe, or early, middle, late is classic. It will stay in clinical practice, and it's part of the World Alzheimer Report that will be out September 21st. For each stage, symptomatic stage, we have a set of recommendations, what to do, what to plan for, who you should see, etc. Now, the new staging of Alzheimer's disease in 6 stages, 3 being before dementia, are accelerating research for what you may call secondary prevention. So you don't progress to the next clinical stage or the next biologic stage. And my concern, of course, is that PET scans and spinal fluid is not going to be available around the world. We need to find simpler ways to stage dementia and Alzheimer's disease in particular. I hope the blood test will work out, but it's really new hope for earlier treatment, especially in younger people. This is a reference that you can access that summarizes most of what I just said. And thank you, Claire, for the opportunity to share this information with the audience and you.
So I have quite a few questions. Thank you for that really thorough presentation. So I'm going to put myself in the place of our viewers. So what type of healthcare professional is qualified to do these type of tests, to do the staging? Because it's for somebody that's at home right now who may have a loved one who is showing these type of symptoms. Probably a lot of the questions are, well, who do I take them to see? Is a family doctor qualified to do this type of diagnosis and assessment?
Okay, we're talking about post-diagnosis here. So we're talking about people who already have symptoms. They may be very mild or not, but somebody has made the workup and say, okay, you have dementia. It's mild, moderate, or severe. That can be stated by family doctors when they have the appropriate information collected. So I hope some nurses who have special interest in training in the field of dementia also can help with that. Certainly occupational therapists, nurses, social workers. Staging based on symptom is established around the world among all clinicians. Your question is very important. How can we diagnose Alzheimer's disease before dementia? And we're not there yet. So it would have to be currently a specialized center, probably a neurologist, but possibly a geriatrician or a neuropsychiatrist with special interest in Alzheimer's disease. We have a clinic specialized across Quebec and the rest of the country. Mm-hmm. The blood tests are not yet fully validated for use, even in the specialized clinics. It's still work in progress. But 2-3 years should be sufficient to start using blood tests in primary care. That would be the family doctor who has a special interest. And they may be used for screening. So someone who looks like he has mild dementia, who has a positive test on the blood for p-tau, then if he or she's young enough before age 80, just pick an age, and motivated and in good general health, maybe he or she should go straight to a special clinic where they have innovative treatments to try, or innovative treatments already in pharmacies, but you need to be biologically classified as dementia due to Alzheimer's disease or due to another pathology.
Now, you and I, a few months ago, did a very important webcast on the journey through a diagnosis of dementia, which I highly encourage our viewers to go and watch because you really explain the diagnosis process. But listening to the staging presentation, it's very clear that you as a clinician are dependent on the information that me, the family member or the neighbor or the friend, whoever is the closest to the person, you're really dependent on the information that I'm going to provide you with regards to the symptoms, correct?
For the symptoms, staging, absolutely. And if you see the person alone, you cannot easily give a clinical stage. You need a collateral information from coworkers, family members, neighbors. Sometimes you do have to send a health professional to the house to actually see the person, make tea and handle some house tasks. Absolutely.
So, and you know, people watching today, their loved one, because many people don't have access necessarily to a family doctor, or a lot of people, we know that across the world, there's a complete lack of awareness of the signs and symptoms of dementia. You know, you mentioned today that it's not only memory, it could be behavior changes. But just very briefly, because I think it's important to reemphasize this, for somebody who will be going to see a doctor for the very first time, okay, to get that initial diagnosis, what do you recommend people bring with them? We talk about list of medications. What do you recommend people bring with them?
Well, it sometimes helps to have a list of the symptoms that are worrisome, a bit of practical advice between you and I and everybody else, limit it to one page. It's more than one page. It's difficult for the clinician to really go through the material during the time available. But one page may be sufficient with some bullet points. What are the key things that you're worried about? And then the clinician normally would, okay, that's what you're worried about. Let's take some time to probe into this. And if it's not enough time, because it's a short visit, they'll be brought back. This is something Ken Rockwood in Halifax has documented, that it takes a lot more than one visit to really pin down all the symptoms, as you said, and all the other factors at play in someone's life, especially someone who has other conditions, diabetes, high blood pressure, and maybe alone, etc. So you may need more than one visit. You know, we've said it before, you need at least 3 visits before you would say, my diagnosis is, and the stage is that. So you cannot do that just on one visit.
And so let's talk now post-diagnosis. So you've met the patient, you assess that they're in the 3rd stage of dementia. How frequently should people come to see you so that you can assess how quickly or not the disease is evolving? Like, should people go and see their doctor every 6 months, every year? How often should they be seen?
Well, that depends a lot on the general health of that person. Most people over age 80 have other conditions that require follow-ups, high blood pressure, diabetes, etc. Sometimes we actually take pills away when you reach a certain age, like statins over age 85, you stop them. High blood pressure pills should be decreased progressively. So there are other reasons to monitor someone with dementia, whatever stage they're at. Now, usually, if you're in mild dementia, you take, if you wish, the available medicines for symptoms, and once a year follow-up is quite adequate if you're in good general health. In moderate stage, you need more supervision at home. Probably every 6 months would be better if there's no other things to monitor, because things change more rapidly. You need to think, is there enough help at home? And moderate, what you said, the 3rd stage, which would be severe, then you usually are in a residence or a nursing home setting or long-term care facility, and then it's a different kind of management.
Mm-hmm. So I'm going to ask you, but this is a tricky question maybe. So for people watching, how do you answer the question, why bother getting an assessment? Why bother going through all of this if there's no cure right now? Like, why can't we just why bother getting a diagnosis if there's no cure?
Well, you could say that about nearly every other medical condition, like cancer of a certain type and diabetes, ultimately. No, there are treatments. Cure, good for you to hope, but there's a lot of treatments. And it's not always a pill. It's really just talking and having the resources to stay home safely. And that's your credo, that's your vocation. So no cure, but good management, some treatments, and more to come.
And I think what people don't necessarily realize is that in the early stages, the person still physically appears fine, and and you can't imagine how the disease is going to evolve. But education is key, because as the disease evolves, it does have a toll not only on the person's cognitive well-being, but also physically, and it does take a toll on the caregiver. So it is important to always reach out, get an assessment by the medical community, make sure that you get support for yourself, and just be as educated as possible, understand the full evolution of the disease. We produced at the McGill Dementia Education Program an amazing guidebook called the Dementia Companion Book that can be downloaded on our website. It's available in multiple languages, and there's much more information about how the disease progresses in there. Thank you, Dr. Gauthier.
Furthermore, yes. In Montreal in particular, you can participate in research. You can volunteer.
So how do people do that? Please tell us, how do people do that?
They just go to a clinic that has a special cohort, like we do at McGill, and you sign up, and you get extra supervision during the course of disease, and you help a lot of people around you and worldwide. Thank you for the participants in research.
Yeah, that resource is available on our website. Thank you very much, Dr. Gauthier, for being with us today.
It's a pleasure. Bonjour.
This webcast is an initiative of the McGill Dementia Education Program, which is funded by private donations. If you would like to make a contribution to our program, please go to mcgill.ca/dementia. I would once again like to thank the Amelia Saputo Community Outreach for Dementia Care for supporting McGill Cares. If you would like to join our mailing list and be notified of upcoming episodes of McGill Cares, as well as really finding out about so many important initiatives that we are doing at the Dementia Education Program, please email us at dementia@mcgill.ca. Thank you for watching.